My name is Jessica Halsey with the Addiction Policy Forum, and thank you so much for joining us this afternoon for our webinar on Xylazine prevalence and response strategies. The Addiction Policy Forum, APF, is part of the Coordination and Translation Center for JCOIN, the Justice Community Opioid Innovation Network. JCOIN is working to study and disseminate solutions to improve care and outcomes for individuals with substance use disorders in justice settings. And we're really excited to be a part of that JCOIN team. Today's session is part of the JCOIN speaker series, where we feature priority topics identified by you, the field, in a very diverse field. And we feature the latest in science, researchers in the topic, and innovations from our community as well. So today, dig in on both prevalence toxicology of xylazine, some of the strategies and the work that some of our public health departments are doing and really leading, and what healthcare professionals and criminal justice practitioners can do to respond. Before we get started, I also want to thank the team at APF, Braden Kelly and Julia Rosenberg in particular, for all the work in pulling this together. It did such a great job and have really coordinated so well with our JCOIN network to pull these topics together and bring some great speakers and subject matter experts into these webinars. We have an amazing lineup of speakers for you all this afternoon. So I'm going to run through a really quick list, and then we'll just dig right into it, and I'll turn it over to Julia at NIDA. But Dr. Julia Zur is a program officer at NIDA, the National Institute on Drug Abuse, in the Services Research Branch. Dr. Zur's portfolio includes research on harm reduction, stigma, health policy, and opioid use disorder treatment. And she also leads NIDA's Harm Reduction Research Network. We also have with us Dr. Carissa, who's a health scientist in the Division of Overdose Prevention in CDC's National Center for Injury Prevention and Control. She serves as a science officer focusing on mortality-related activities for CDC's Overdose Data to Action program. We also have with us Risha Renaud from ASTHO. She's a senior director for the overdose prevention at the Association of State and Territorial Health Officials. That is always a mouthful for me, so ASTHO, where she leads ASTHO's technical assistance and capacity building with states and territories related to overdose prevention, preparedness, response, and surveillance. We also have with us Dr. Megan Reed, who's an assistant professor in the Center for Connected Care, the Department of Emergency Medicine, and the College of Population Health at Thomas Jefferson University. And last but not least, we have Dr. Tracy Green, who's a professor and director of the Opioid Policy Research Collaborative at Brandeis University. She's also the adjunct professor at the Warren Alpert School of Medicine at Brown University, where she co-directs the Center of Biomedical Research Excellence on Opioids and Overdose at Rhode Island Hospital. So amazing lineup and great subject matter experts on this topic. So really grateful to you all for taking the time to be with us today and really respond in real time to our JCOIN network's request to really dig in on xylazine. I think I'll start it off by turning it over to Dr. Julia Zur, our program officer at NIDA.
Thanks, Jess, and thank you everyone for being here. Like Jess said, my name is Julia Zur, and I'm a program officer at NIDA, the National Institute on Drug Abuse. And I'm part of the JCOIN team, which is sponsoring this webinar. So for those not familiar with JCOIN, I wanted to just give a little bit of background. So JCOIN, like Jess said, stands for the Justice Community Opioid Innovation Network. It was developed and is led by Dr. Tisha Wiley, who unfortunately couldn't be here today, so I'm filling in for her. But before the webinar starts, I just want to give you a little bit of background. So JCOIN was launched in 2019 by NIDA with support from the HEAL Initiative, which stands for Helping to End Addiction Long-Term. And the mission of JCOIN is to support research that aims to ensure that everyone who is involved with who comes into contact with the criminal legal system, who has a substance use disorder, has access to effective treatment, whether they are detained in jail or prison or in the community. And so although NIDA has been investing in research on the criminal legal system for many years, this was the largest investment that the NIH had ever made. So this was a really huge development for the field. And in addition to research on, to supporting research, a big goal of JCOIN is to ensure that the research is translated into practice and is made accessible to a broad audience. And so we're very grateful for Jess and her team at the Addiction Policy Forum, who have really helped us make this goal a reality. And they've developed all sorts of translation products and this webinar and all sorts of other resources. So when I'm done speaking, I can actually put in the chat the website, JCOIN-CTC.org, which I'd encourage you all to look at. There should be all sorts of resources that can help a broad range of audiences. And so, we always want to be responsive to what's going on in the field at JCOIN and NIDA more broadly. And so we're really grateful to be able to be supporting this webinar on Xylazine, and I'm grateful to all of you for attending and for the large amount of interest in this topic. So we have a great panel of experts, and so I'm grateful and hopeful that we can all make progress toward achieving the goals of JCOIN and addressing the need for addiction treatment more broadly. So with that, I will turn it back over to Jess.
Oh, thank you so much. So so I'll turn it over to Dr. Carissa from the CDC to give us an overview and an update on what the CDC's work has really been around Xylazine.
Thank you so much, Jessica. I'll go ahead and share my screen. Oops. All right, are you guys able to see the screen?
Looks great.
Awesome. All right, so as mentioned, my name is Babazi Carissa, and I'm really happy to be here to talk about an MMWR we released a few months ago now, where we looked at Xylazine detection in illicitly manufactured fentanyl-involved overdose deaths. So before I get into the presentation, I just want to share a general disclaimer that the findings and conclusions of this presentation are those of the authors and don't necessarily represent the official position of the CDC. So before I get really started into our specific work, I just wanted to do a little bit of level setting and talk a bit about what Xylazine is. So Xylazine is a non-opioid sedative. It's not approved for use in humans according to the Food and Drug Administration. There have been some studies that have looked at the effects of Xylazine in humans, and those have suggested that when humans are exposed to Xylazine, it can actually act as a central nervous system depressant and can cause things like hypotension and respiratory depression. Because it's not an opioid, it doesn't respond to opioid reversal agents such as naloxone. However, we always recommend that naloxone be administered in the event that Xylazine exposure is suspected, because we often find it in IMF products. So as many of you are aware, there has been a lot of attention on Xylazine recently, and this is just sort of an example of some of the headlines and alerts that have been associated with Xylazine in recent months. So the first one on the left-hand side is about an article that came out in the New York Times that talks specifically about the impact of Xylazine in certain hard-hit communities like Philadelphia. We've also seen a number of alerts that have been issued by federal agencies. Specifically, we've seen alerts from the Drug Enforcement Administration on the threat of fentanyl mixed with Xylazine. We've also had the FDA have an import alert designation for Xylazine, so that's specifically on Xylazine shipments coming to the United States. More recently, we've had movement from Congress, so there's been some proposed legislation to make Xylazine a controlled substance. And the Biden administration has actually declared Xylazine adulterated fentanyl as an emerging threat. So there's been a lot of intense focus in recent months on Xylazine and its potential morbidity and mortality overdose risks. So this is just what our MMWR was titled. So illicitly manufactured fentanyl-involved overdose deaths with detected Xylazine, and was an analysis we did from January 2019 to June of 2022. So this is just the page, and I can also include the link to the MMWR in the chat once it's complete, once the presentation is completed. But we had sort of specific questions that we were interested in answering for this analysis. So we had been hearing, anecdotally and also just generally reports of increasing presence of Xylazine in IMF drug products, as well as in drug overdose deaths. But we had a couple of questions. So we weren't really sure how frequently medical examiners or coroners were actually specifically listing Xylazine as contributing or causing the death in these IMF-involved overdoses. We also weren't really sure what the geographic distribution of these deaths were. So what did it look like when we saw Xylazine detected in IMF-involved overdoses? Was it sort of consistently spread out across the US, or were there some regions that were harder hit? So in order to do our analysis, we relied on our fatal overdose surveillance system. So that's the State Unintentional Drug Overdose Reporting System, or SUDRS. And SUDRS funds actually 47 states and the District of Columbia to collect data on unintentional and undetermined intent drug overdose deaths. So on this figure here, you can see the jurisdictions that are funded to participate in SUDRS. So the jurisdictions funded in the dark purple are the ones that are funded to collect data on for the full jurisdiction. So that's for all unintentional and undetermined intent overdose deaths in the jurisdiction. The ones that are shaded in the light purple are funded to collect data in a subset of counties. So they'll collect data on just a certain number of overdose deaths in their jurisdictions that occur in those counties. And then we have 3 jurisdictions that did not participate as they were not funded to participate in SUDRS. So those were North Dakota, Wyoming, and Texas. So here you have sort of a diagram of how the data is collected and abstracted into our system. So we have 3 main data sources that we require. We require death certificate data, we require medical examiner or coroner reports, and we also require postmortem toxicology results. And those 3 data sources are then reviewed by abstractors and then entered into our system. And we are able to capture over 600 data elements. It's a pretty comprehensive system. So we capture things ranging from demographics to overdose risk factors, comorbidities, contributing drugs, as well as circumstances or other characteristics associated with the overdose. So for our analysis, we had 3 specific aims. So the first was just to essentially assess trends over time. So for the analysis period that we were focused on, we wanted to see how xylazine detection or co-involvement was changing when we looked specifically at IMF-involved deaths. So we had 3 trends we looked at. So we looked at the monthly count of IMF for fentanyl-involved deaths where xylazine was detected. We also looked at the monthly counts of IMF-involved deaths where xylazine was co-involved. That means where xylazine was specifically listed on the death certificate as contributing to the death. And lastly, because we wanted to see if this was a true increase over time, we looked at the monthly proportion of fentanyl-involved deaths where xylazine was detected. We also wanted to look at 2 groups. So because we were focusing on fentanyl-involved overdoses specifically, we wanted to compare fentanyl-involved overdoses where xylazine was detected to fentanyl-involved overdoses where xylazine was not detected. And we did this among for the most recent 18 months of data that we had. So from January 2021 to June of 2022. And this was among 32 jurisdictions that had complete data. And we compared those 2 groups and looked specifically to see if there were any differences when it came to things like, demographics, geography, whether certain drugs were co-involved in the overdose, or if there were any differences when it came to certain characteristics or circumstances associated with the overdose. And lastly, a big thing we were interested in looking at was essentially how the prevalence looked. So when we mapped the number of IMF-involved deaths where xylazine was either detected or listed as co-involved, how did that look across the United States? So we mapped it for 32 jurisdictions who had data from January 2021 to June of 2022. And we also wanted to see specifically how often medical examiners or coroners were listing xylazine as contributing to the death when it was detected as present on postmortem toxicology. We knew that this wasn't necessarily happening all the time, but we didn't have a specific idea of what the actual numbers were. So that was also an additional map that we looked at as well. So this is the first set of results. So this is the trend figure. So looking essentially at how xylazine detection or xylazine co-involvement changed over time for our analysis period. And you can see pretty much right away that there was a notable increase from January 2019 to June of 2022. So the line in the middle, the solid blue line, corresponds to the number of fentanyl-involved deaths where xylazine was detected. So that increased about 6-fold from about 33 deaths to about 233 deaths in June of 2022. We also saw an increase, about a 16-fold increase in the number of fentanyl-involved overdoses where xylazine was specifically listed as causing or contributing to the death. So that's the dashed line you see at the bottom of the graph. So that increased pretty significantly as well. And lastly, to see if this was a true increase over time, we wanted to look at the proportion of deaths, specifically the proportion of fentanyl-involved deaths where xylazine was detected. And that increased by about 276% from 2.9% in January of 2019 to nearly 11% in June of 2022. So there's a pretty big increase in xylazine detection across the time frame of our analysis. So when it came to looking at differences in essentially characteristics between fentanyl-involved overdoses where xylazine was detected and fentanyl-involved overdoses where xylazine was not detected, we looked at a number of different factors. So the first were demographics. We really didn't see any big differences when it came to demographics. So here we have the sex breakdown. We had about 9% of fentanyl-involved overdoses that actually had xylazine detected, and the rest did not have xylazine detected. So you can see when we compare those two groups that the sex breakdown is pretty much the same. But we did see a difference here when we looked at the regional breakdown. So when we looked at the proportion of fentanyl-involved overdoses where xylazine was detected, nearly half of those took place in the Northeast, so 49.9%. In comparison, when we look at fentanyl-involved overdoses where xylazine was not detected, that was a bit more mixed. So we had the largest proportion in the Midwest, about 29.2% of those occurred in the Midwest, followed by about 28.5% that occurred in the Northeast. So there's a big difference here in regional distribution when we compared the two groups. When we go back again to demographics, we looked specifically to see if there are any differences by race and ethnicity. Here we didn't find any differences really that stood out to us. The majority of deaths were among white non-Hispanics, so about 2/3 of deaths occurred among white non-Hispanics, and that was followed by Black non-Hispanics and Hispanics. We were also able to look at what other drugs were listed as contributing to the death for these two groups. So here we looked at drugs like methamphetamine, cocaine, benzodiazepines, alcohol, prescription opioids, and heroin. What we saw here was the largest proportion of deaths tended to have methamphetamine and cocaine as being listed on the death certificate, but this wasn't notably different for both groups. So we didn't really see any differences that stood out to us when we looked at the proportion of deaths where there were other drugs listed as contributing to the death. So the majority of them had methamphetamine or cocaine listed, and then this was followed by benzodiazepines, alcohol, and prescription opioids. With our data, as I mentioned, it's a pretty comprehensive surveillance system. So we're able to look at quite a number of different characteristics associated with the overdose. So we can look at things like whether the decedent had a history of homelessness or housing instability, if they had been seen in the emergency department, if they had current or past treatment for substance use disorders, or if they had a history of mental health diagnosis. So we looked at a number of these different circumstances or characteristics. And while we didn't really see any big differences that kind of stood out to us for most of them, we did see a difference when it came to if there was evidence of no pulse at first responder arrival. So among IMF or fentanyl-involved overdoses, where xylazine was detected, this proportion was actually lower than for fentanyl-involved overdoses where xylazine was not detected. So this was an interesting finding to us when we compare sort of specific characteristics of overdose deaths looking at these two groups. We also looked at the route of drug administration. So here we found that injection was the most common route of drug administration for fentanyl-involved overdoses where xylazine was detected. And in comparison, for fentanyl-involved overdoses where xylazine was not detected, the most common route was smoking. So this was a pretty interesting finding for us as well. And lastly, as I mentioned, we wanted to look at the prevalence of fentanyl-involved overdoses where xylazine was detected or co-involved across our analysis period. And so this first map looks specifically at xylazine detection in fentanyl-involved overdoses. And the darker colors correspond to a higher number of deaths. So you tend to see here a concentration in the eastern part of the United States, particularly the northeastern part of the United States, where we saw higher xylazine detection in fentanyl-involved overdoses. And this essentially mirrors what we saw earlier when we looked at that breakdown by geographic distribution, comparing the two groups, showing a higher proportion of xylazine detection among fentanyl-involved overdoses in the Northeast. We then also look specifically at xylazine co-involvement. So this is where xylazine was listed as causing the death on the death certificate. And this tended, again, to be kind of similar to what we saw earlier. So a higher proportion of deaths, again, were in the Northeast. But when we looked at instances where xylazine was detected as present on postmortem toxicology and also listed as contributing to the death, according to the medical examiner or coroner, this was more mixed. So again, the darker colors here indicate a higher proportion of instances where that happened, and then the lighter colors indicate a lower proportion. So here we have a variety of states where coroners or medical examiners may have been more likely to indicate or list xylazine as contributing to the death when it was detected as present on postmortem toxicology. And in some instances, it didn't happen as frequently or happened rarely. So that was a notable finding. And it's not really clear why there's that difference in terms of how why medical examiners or coroners may make different determinations on whether xylazine would contribute or cause the death. But that was something we found that varied quite a bit by jurisdiction. So those were sort of our main findings from our analysis, but we did have a few important limitations. So you could tell from our analysis that while we do fund 47 states and the District of Columbia to participate in suitors, we can't include all of those jurisdictions due to the data limitations. So we focus on states or jurisdictions that had complete data for the analysis period that we were focusing on. And because of that, our analysis isn't nationally representative and the results might not be generalizable. We also have a significant limitation when it comes to the tox testing for xylazine. So we know that it's not uniform across the US. Even now, there are some jurisdictions that don't test for xylazine. And even across our time period of analysis, we know that there's some jurisdictions that may have started testing for xylazine later on in the time period, as opposed to the very beginning. So because of that, we could have a likely underestimate of the true prevalence of xylazine in overdose deaths, and it could also potentially overestimate the true increase during the analysis period. So we have some pretty significant key takeaways. The first is the monthly proportion of IMF-involved deaths did increase notably by about 276% from about 3% in January 2019 to nearly 11% in June of 2022. While xylazine detection was less than 12% among fentanyl-involved overdoses overall, it tended to vary by jurisdiction and was highest in the Northeast. We also saw that coroners or medical examiners did not always assign or list xylazine as causing the death when it was detected as present on postmortem toxicology. When it came to decedent demographics or overdose circumstances, we really didn't see any big differences there when we compared IMF-involved overdoses where xylazine was detected compared to IMF-involved overdoses where xylazine was not detected. We did see a few differences for certain specific circumstances, so particularly where there was no evidence, where there was evidence of no pulse when first responders arrived, and also when it came to the route of drug administration. So some pretty important public health implications as a result of our analysis are that naloxone should be administered to reverse the effects of opioids, even if xylazine is suspected to be present, because xylazine is mainly found in IMF products. We also stress that supportive care is really critical in the event of an overdose involving xylazine, and certain harm reduction tools like the provision of xylazine testing strips could really be helpful in intervention efforts. We do stress also the importance of continued surveillance. As I mentioned, xylazine prevalence really could be underestimated because of that testing variability we saw across jurisdictions and across our time frame of analysis. So it's really important to implement routine standardized toxicology testing for xylazine. And that's in order for us to really understand better how xylazine works in terms of overdose mortality and morbidity risk. And we also need to know a little bit more about the motivation specifically for adding xylazine to IMF products. There's still not a lot of information or research on why that's happening, and it would be really important to get more data on that. So lastly, just some key steps I want to share. It's really important to call 911 immediately if you recognize an overdose, or if you're resuscitating a patient or administering naloxone. If you do have an overdose where naloxone administration seems to be ineffective, maybe considering xylazine as a potential contributor could be also helpful. It's also important to provide rescue breaths. I also want to stress the importance of linking people who are at risk for overdose with care, and also providing test strips. So fentanyl test strips and xylazine test strips as well for people who use drugs as part of community drug checking programs. And lastly, there's a lot out there about xylazine, but it's really important to educate the public on the increasing presence of xylazine in the drug supply. We know that's likely changing over time, and also on how to respond to xylazine-involved overdoses. And with that, I'd like to just acknowledge the jurisdictions and partners participating in OD2A, as well as thank the co-authors for this MMWR. Thank you.
Thank you so much, Dr. Carissa. Very, very helpful. Thank you for all the work that the CDC has been doing to give us the latest data and synthesize that for some key takeaways too. Risha, can I turn the mic over to you?
Absolutely, and thank you. And I will just work on sharing my screen here. All right, is everyone able to see my screen, my slides?
Looks great.
Awesome. All right, well, hello everyone, good afternoon, good morning, depending on where you are. My name again is Risha Ranade. I'm the Senior Director for Overdose Prevention at the Association of State and Territorial Health Officials, or ASTO, and I'm just going to be talking a little bit about what we've seen in states related to xylazine and its impacts. If I can, there we go, getting my slide to advance. So just a little bit of background on ASTO and who we are. We are a national nonprofit membership organization, and we represent the public health officials in the 50 states, Washington, D.C., 5 U.S. territories, and 3 freely associated states. And as an organization, we do a lot of technical assistance and capacity building with public health officials and their agencies. And my department, which is overdose prevention, focuses on TA related to overdose prevention. And so as we engage with states in their efforts to respond to xylazine, we do monitor what's going on federally that may affect the landscape for states. So Dr. Carissa just talked in detail about the MMWR that CDC released earlier this summer. That information and data and recommendations are incredibly important for informing state efforts. Some of the other resources and strategies that we've seen include a 2022 DEA Joint Intelligence Report on concerning increases in xylazine-involved overdose deaths. In March of 2023, SAMHSA published a Dear Colleague letter to alert their grantees, as well as healthcare providers, about the prevalence of and dangers of xylazine. 2 bills, I think as Dr. Carissa also mentioned, have been introduced in Congress this year, primarily aimed at regulating xylazine and increasing the penalties for trafficking it. And then in April of this year, the Biden-Harris administration designated fentanyl combined with xylazine as an emerging threat to the United States. This designation was then followed up by the release of a xylazine response plan from the White House Office of National Drug Control Policy, or ONDCP. So I do want to talk a little bit about the ONDCP fentanyl adulterated or associated with xylazine response plan, which has 6 pillars. And the reasons I want to talk a little bit more in detail about this is because you will see these priorities, I think, reflected in the state strategies that I'll be talking about later and probably kind of reiterated throughout. The first pillar is testing, which we heard a lot about from Dr. Carissa. And that testing pillar is really focused on improving and standardizing forensic testing for xylazine, as well as improving testing in clinical settings. The next pillar is data collection, which is focused on enhancing the epidemiological surveillance of xylazine. Evidence-based prevention, harm reduction, and treatment aims to develop a framework for treatment and overdose response. Supply reduction is really focused on identifying the illicit supply chain. Regulatory control is really looking at exploring scheduling xylazine under the Controlled Substances Act. And then finally, research is really focused on understanding the impact of xylazine on the human body. We're still learning a lot about xylazine and its physiological effects. And so that was just some of what we've seen at the federal level in terms of priorities and response activities. I'm going to move now into what we've seen in the states, and I want to just make a note that this is a really rapidly evolving area as we learn more about xylazine, its prevalence, and how it affects people. And so this isn't likely to capture every single state effort. It's maybe since the start of this webinar, more initiatives have gotten geared up in some places. So this will focus rather on some of the major themes that we've seen. So some of the earliest state public health efforts that we saw focused heavily on raising awareness in communities about the presence of xylazine and the risks associated with its use. These efforts really seek to educate the public, including people who use drugs, about harm reduction resources, the continued importance of naloxone when someone is experiencing an overdose, and where to find services like wound care. This information is made available through numerous different state websites, flyers, and other public health campaign materials. We've looked at as many of these resources and campaign materials that we can get our hands on, and they're pretty consistent in what they tend to include. And they're really all looking to answer questions like, what is xylazine and why is it causing concern? How does xylazine affect people who encounter it or who use it? What can people do to reduce the risk of a xylazine-involved overdose? What you can do if someone nearby is experiencing an overdose? And very importantly, where in your community you can find harm reduction resources. So the second area in which we've seen state response activities is in testing. Xylazine, as Dr. Krisa mentioned, is generally not a part of routine toxicology testing, which can make it challenging for states to know the true scope of the issue and how different communities in their state may be affected. Some states like Connecticut have worked with hospitals to test those who experience a non-fatal overdose for xylazine. And those partnerships with hospitals and labs are really important so that overdose prevention efforts can be really data informed and data driven, and states can understand what they're seeing in their supply, including xylazine. Some states are also advancing the use of xylazine test strips. Those can be used to test drug samples to determine whether they contain xylazine. These test strips are similar to fentanyl test strips, which have been around a little bit longer, so you may be more familiar with them. These test strips allow people who use drugs to make informed decisions about whether and how much of a substance they want to consume. And then point of care drug checking sites have a similar goal, and these are locations where people who use drugs can have their supply checked for the presence of xylazine or fentanyl. Some localities have made fentanyl test strips available to people who are leaving jail or other carceral settings. As xylazine test strips are more newly available, we may begin to see those utilized more broadly as well. And just kind of reiterating the point that data from toxicology testing and perhaps also from point of care drug checking sites can be used on a broader scale to understand the prevalence of xylazine, both in states and around the country. So the degree to which states can implement some of these xylazine response strategies, especially the harm reduction focused ones, depend in a lot of cases on state regulation and legislation. And so the third area where we've seen a lot of increase in activity is in state regulatory and legislative activities related to xylazine. For a long time, many state drug paraphernalia laws have prohibited the use of drug checking equipment, including test strips. As of a recent scan that our team just did with our state health policy team at ASTO, there are 28 states that legally authorize the use of fentanyl test strips. Again, with xylazine test strips being more newly available, legal authorization is a little bit more variable and can depend on how state laws are written. New Hampshire, for example, just removed both fentanyl and xylazine testing equipment from their definition of drug paraphernalia in their state law in the most recent legislative session. And we mentioned earlier the importance of toxicology testing. Indiana just passed a law this year requiring all of their coroners to test for xylazine in cases of suspected overdose. That's the only state that I'm familiar with so far that has mandated that testing in cases of suspected fatal overdose. And so I'd be curious to see if other states pick that up as well. We've also seen a lot of states move to schedule xylazine as a controlled substance at the state level through state legislation or through regulatory actions. A few states, Ohio is one, have scheduled xylazine through emergency orders. Several more have introduced bills in their state to schedule xylazine. And while scheduling does give public safety entities more tools for addressing the supply of xylazine, scheduling can impact some of the harm reduction strategies that we've been talking about. One state, for example, this year was only able to remove xylazine test strips from their drug paraphernalia law because xylazine was not a scheduled drug in the state. So those are just some of the complexities that states are navigating as they're responding to xylazine and balancing different options that they have within their state. And finally, states are continuing to emphasize access to compassionate care for people who use drugs by making sure that they have access to low barrier harm reduction services and wound care, and continuing to facilitate referrals for medical care, treatment, whatever additional services that may be needed, including mental health services. And I think we're going to be digging into all of this a bit more in the subsequent presentations. And so happy to answer questions during the Q&A. And if anyone is wanting to get in touch to learn a little bit more about ASTA resources, my contact info is on this last slide here. Thanks so much.
Thank you so much, Risha. Really great presentation and overview. I'm going to turn our Zoom mic over to Dr. Reed.
Hi, thank you so much for having me. My name is Megan Reed, and I'm located in Philadelphia at Thomas Jefferson University. And I'm going to be talking today about concerns about xylazine as heard from people who use opioids and service providers and some opportunities for intervention. I'm going to provide some local context and overview of studies that I'll be pulling data from, talk about some of those xylazine concerns, and close with talking about the need for structural interventions and some ideas for first responder interventions. As I mentioned, I'm based out of Philadelphia, which has really been the epicenter of this current stage of the xylazine crisis in the United States. It is spreading rapidly outwards, but we are in a very xylazine saturated drug market. It's in over 90% of our dope or our heroin fentanyl samples. So we are really trying to talk to people here who use drugs and who are working with people who use drugs so that they can provide us their perspectives about what will work to help keep them safer. I'm pulling from 3 studies. One is about fentanyl test strip use outcomes for non-opioid drugs, where the topic of xylazine arose organically. And then 2 are studies in progress. So one is community-informed approaches to the escalating presence of xylazine and opioids. That's a NIDA-funded study. And then the third one is responding to xylazine, PI Mary Jo Larson. So I'm going to present each of these concerns, first give a broad overview about what the concerns are, and then follow up with quotes directly from people who use drugs and from clinicians and harm reduction workers. So the first one is wounds. This has been the primary focus of media coverage to date, and it's been the main thing discussed with xylazine exposure. And I just want to note that our understanding of xylazine wounds is underway. We're learning more every day about their progression, about their cause, and about best practices for wound treatment. So we're making a lot of headway. At the same time, there are still a lot of unknowns. So this first quote is from a person who uses opioids, and he said, "It's not meant for human consumption. I mean, it says right on the bottle, and there's no way to prevent it. I've got wounds in places I don't even get high in." So this person perhaps was injecting in his arm, but he had a wound on his leg. People get wounds in places where they're not injecting. The reason for that is currently unknown. Another person said, I don't even inject and I've got wounds. He'd recently been released from having been incarcerated for a couple of years, and he only sniffed his dope. And he had some wounds on his neck that looked like kind of classic early xylazine wounds. An academic researcher said, and with some wounds, people continue to inject in that spot because it's a spot that they know they can fit and stay well. So some of the various interventions that I've seen are hand washing stations on the street or in harm reduction organizations, having access to showers 24 hours a day and not just at night if you're in a shelter or something like that. A second one that's been mentioned a bit today has been overdose response. So the importance of continuing to respond to overdoses with naloxone, even though, of course, xylazine doesn't respond to naloxone as it's not an opioid. However, a lot of people are reporting that they are being given more naloxone than is needed because the naloxone is removing the fentanyl portion of the overdose, but the xylazine is still on board. So the breathing is restored, but they're so heavily sedated that they're still unconscious. People are continuing to give naloxone. And that can have poor outcomes because the more naloxone somebody's given, the more likely it is that they are to have withdrawal. And if it's severe, they're going to, when they are revived, they're going to go out and use again and perhaps go into another overdose that could be fatal. So what changes, if any, should be made to overdose response training and practices? A person who uses opioids said, people need to know that if a person is overdosing on xylazine but still breathing, and in some small way, some small bit coherent, do not Narcan them. Somebody who works in the field of harm reduction said it's important to be educating people around them around responding to their overdose so that they're not being over Narcaned by people around them, especially if they live in a community that is xylazine naive. Just giving them more information about, like, don't give me 4 Narcans because I'm not responding. So really focus more on providing overdose prevention education that's focused more on breathing and the pulse than on just responsiveness. So really underscoring the need for rescue breathing, monitoring pulse, monitoring the breathing, and not giving more naloxone once breathing is restored. Next, I want to talk about xylazine withdrawal. It's currently poorly understood, but it is marked by extreme physical discomfort and anxiety. And there is a lack of consensus currently on the best approaches to treat withdrawal. Those protocols are still in development. Even here in Philadelphia, the hospitals all talk together about their current approaches and are trying different things out and finding the best protocols. Withdrawal is a barrier to accessing treatment for substance use disorder or medical care. And I will say that I talk to people frequently who have really severe xylazine wounds, but they say that the wounds really pale in comparison to the discomfort of withdrawal. So it's pretty extreme. One person said it's like one of the worst detoxes right now because the rehabs can't seem to find something to help with the withdrawal. And the tranquilizer is the worst habit to kick because apparently it takes 2 to 4 weeks to get off of it. So these are people who are attempting to access treatment for opioid use disorder, but the withdrawal is so agonizing that they eventually leave to use again. Another person said that he'd been using for 40 years and it's around the clock. I wake up, go to sleep an hour, wake up, I'm sick. It wakes you up and you got to get high and go back to sleep. Like you might have extreme anxiety or start physically detoxing, sweating, and expletive. So here he's talking about not just how bad the withdrawal is, but how quickly it seems to hit. And this is something that I've heard echoed by many, many people who use opioids, as well as many clinicians who are working with people who use opioids in Philadelphia. Another person said, we've had people who are just finding a much harder time making it to their appointments on time, making it to their appointments when they're supposed to return, because they can't get themselves together enough to make it there. Like they're so focused on not being sick, or if they're there, they're leaving if they have to wait because they're feeling really sick. So people are feeling really tethered to the communities in which they are buying and using substances, and they're unable to make appointments for other reasons. And so this might mean that some people who are more stable in their substance use might become more unstable over time, have more difficulty with employment and maintaining housing, etc. One thing that I think is very under discussed currently is risks related to xylazine sedation. So there are kind of 3 risks that I'm talking about here. The first is concerns about the risk of limb injury from immobility that can span hours. So if somebody's heavily sedated and unconscious and maybe their arm is pinned under their body, risks of the loss of blood flow to that limb. But the 2 that I'm going to talk about are physical injury due to conscious sedation, which would be, you know, they're walking around, but they're not really conscious of what's going on. And afterwards, they don't really remember what happened. And then safety, so losing personal possessions and being at risk for physical and sexual assault. One person said, and they hate when they get it by accident, so it being xylazine, which is referred to locally as tranq, because a lot of times bad things will happen to them. They'll pass out somewhere, get robbed, won't remember what happened, all kinds of crazy stuff. Because there's a lot of people out here that love tranq. I don't know why, because it literally puts you out, and then that's when people rob your stuff. A clinician said, we give you a string backpack with all the supplies or a plastic baggie with all the supplies, and yet, you know, how could you hold on to something if you're asleep, especially in a place where it's like do or die, and you need to just take people's stuff to have anything. And an academic researcher said, if somebody were to go into withdrawal while they're monitoring somebody else, it's really painful. And we're talking about the intensity of withdrawal being so much more anguishing than previous years. And so the withdrawal that somebody might go into, they have to take that risk calculation of, I want to monitor this person that I care about, and I don't want them to die. But I'm also starting to experience this anguish that is only going to intensify if I don't go take care of it right now. And one of the things that people are doing to battle the heavy sedation from xylazine is increasing their stimulant use. So we are in the fourth wave of the current overdose crisis. It's marked by polysubstance use, which is primarily opioid overdoses with stimulants on board. In Philadelphia, cocaine, both powder and crack cocaine, are more heavily used than methamphetamine, although I'm hearing many more reports of meth use increasing here where I'm located. A clinician said, I think it's a lot of polysubstance use. I think people are using crack and meth at much higher rates than they were before, just to balance themselves out and try to stay awake, because it doesn't really matter how much you do, you're going to be sedated almost instantly. I've seen a lot more meth use than I ever have. Somebody who works in harm reduction said, we provide 2 different kinds of pipes that people can use to smoke both crack and meth. And then in those kits, we provide alcohol pads and mouthpieces and these things that we would hope that would keep people safe. One other thing I know about stimulant safety is we always include hard candy or gum to help increase saliva production, which is to promote dental health. So one of the xylazine interventions we could think about developing are actually safer stimulant usage. And xylazine test strips have come up. I'm only going to touch on them briefly. They are commercially available now. There are multiple distributors and manufacturers. Sensitivity and specificity analyses are ongoing. It's incredibly critical that we field test these products and to see what people are doing in real life circumstances. And there are issues with cross-reactivity with lidocaine and diphenhydramine. Some things that people have said about xylazine test strips is a couple of years ago, a lot of people that I was interviewing said that they wanted them. They didn't exist yet, but they were saying if these hypothetical test strips existed, I would love to use them. Now, when I talk to people, it's just a couple of years later, people are saying this would no longer be helpful to me because I'm so physically dependent on xylazine that I seek it out because I don't want to go into withdrawal. And so people kind of have the sentiment like this first quote, outside of Philadelphia, where xylazine is just entering the drug market, push more of the test strips. Like I said before, it's too late for us. We already want xylazine, the people that are on it in Philadelphia. Like outside of the city, if they push them, get them out like they do Narcan. And a harm reductionist also echoed the sentiment and said, I guess what I'm trying to say is xylazine test strips aren't as useful as an intervention here in Philadelphia as they would be in a place where you know it's newer. I would say they obviously are less useful in a drug market that is completely saturated with xylazine. And a clinician said, I'm not totally sure they're ready for prime time. I myself am not confident in the sensitivity and specificity of the ones that I have. I think out of context, I'm not sure I trust them yet. And I think it's important to talk about the stigma that people who are using xylazine are facing. People who use drugs obviously face a lot of stigma, but this clip from the media is very representative of a lot of the coverage. So it being referred to as flesh rotting, people being referred to as zombies, very, very stigmatizing language that's not really helping the situation. And just to remind folks that when people experience stigma, they're no longer going to be comfortable talking about their drug use. So they're going to delay care related to their drug use. They're also going to delay care not related to their drug use. So hepatitis C treatment, HIV treatment, or treatment for things like hypertension and diabetes. And so what we're really doing is we have missed opportunities to link people to treatment when we're stigmatizing them. And people are experiencing a lot of stigma in the medical setting. A survey of primary care physicians found that a third of them said that they didn't want to live next to somebody who was taking medications for opioid use disorder, like methadone or buprenorphine. And of course, this varies by race. So Black people are less likely to be linked to evidence-based care than white people. Some things that people have said about stigma. I find this first quote very powerful. She said, they kind of look at you like you have a freaking disease, like you're a walking disease. Like, I know we all look like expletive. I know some of us smell like expletive. Like, seriously, the infections stink. They stink, but it's like, we're people. They look at you and they talk to you and treat you like you're nothing. And a clinician said, let's rise up stigma as well in fear of being judged by going into a hospital to seek further care. Anybody that I've interviewed, they commonly say, I'm afraid the doctors are going to make me feel like I'm gross and that I stink and that nobody wants to come near me, which is sad. And finally, a third clinician said, my perception is some people don't mind as much about the wound, but the stigma and shame they feel is just so absolutely distressing to them, or, the smell of the wound. So taken together, what are the intervention needs? We are taking a lot of this data to develop individual level interventions to address some of these concerns. So addressing overdose response, safety, wound prevention, wound care, among others. But I really want to underscore that we need structural interventions. These are structural problems, and we need to develop those in tandem with individual level interventions to address the root causes of problems from xylazine adulteration. So for example, one of the things that I'm asking people is, how can people who are using xylazine stay safer from sexual assault or physical assault? And there's very little that individuals themselves can do. What we need to do is explore things like overdose prevention sites and observation centers and places where people can be safe after they've used xylazine while they live in a drug market that contains a lot of xylazine. And what role could housing play? Safe, stable, affordable housing. And how can people have access to showers and hand washing on demand so that they can avoid wounds and then treat wounds themselves? And then thinking more about further investments in drug checking. I'm going to close by talking about a few different interventions for first responders. The Responding to Xylazine study that is underway is talking to a lot of people about how first responders can help. And we asked our focus groups with people who use opioids, how do you think police officers could help people who are using xylazine? And this quote is what pretty much every single person said or emphatically nodded to across focus groups. Said, just be a little more understanding or educated about it. Education is where it has to start. They can't help nobody if they don't understand it or have knowledge about it. We're willing to accept any help. A few things that first responders can do is to understand that overdoses might be presenting differently than they did before. So again, it's extremely important to still administer naloxone, but to not keep administering it once breathing is restored, but keep monitoring that breathing and the importance of giving rescue breaths and using things like pulse oximeters. Recognize that withdrawal that you might be seeing in people is described as excruciating, and you may encounter people who are experiencing heightened anxiety and distress. A lot of people are starting to distribute wound care kits and to partner with local harm reduction organizations to coordinate efforts, to understand who is doing the work in your area, and so you can make referrals to people to access services there. And then finally, to pursue public awareness around xylazine. Okay, thank you very much.
Thank you so much, Megan. Really appreciate it. The quotes are so powerful, and I really thank you for doing that work and including them. Tracy, can I turn it over to you?
Wonderful, thank you. My name is Tracy Green, and I'm very happy to share with you some of the research we've been doing on xylazine, some of the trends and responses to complement what you've been hearing throughout the afternoon, throughout these presentations. I'm pulling from a couple different research projects and ongoing work that we're doing in Massachusetts and New England on to understand a little bit more about the trends in the drug supply. Nationally, the drug supply information that we have shows that despite no human consumption, xylazine is increasingly found in it across the US. It has long been seen in Puerto Rico, and our Philadelphia colleagues and have really been experiencing xylazine's presence for some time with great burden, with over 90% of heroin samples also containing xylazine, for instance. Most recently this month, we had additional information from urine drug screen based data from Millennium Health that showed a little bit more of a light on more of the US Census regions, and complementary to the mortality data that you heard earlier. Across the country, we are seeing that xylazine has been detected, but more concentrated in the US Census regions that are in the Mid-Atlantic and the Eastern North Central areas. Where we'd otherwise look with emergency department data show that it is quite lacking. Because most emergency departments don't test for xylazine routinely and it has to be sent out, we rely upon small windows of information from places like Philadelphia. So we have seen in emergency department based studies there that fentanyl positive urine drug screens show xylazine presence is co-occurring. And more recently, a multi-site emergency department study outside of the Philadelphia collection that xylazine-involved overdoses, interestingly, were less severe than overdoses involving just fentanyl. So it's important for us to keep inquiring in this area to just what the sorts of effects are, both the mortality and morbidity effects of xylazine's presence, because I think it's more complicated, as we'll hopefully start to see, and maybe give us insights on how we may better respond. In Massachusetts, the signals about xylazine were detected early. Nearly 2.5 years ago, due to the drug supply data stream, or Massachusetts drug supply data stream, that our group and the state have been funding, we use community drug checking to identify different emerging trends and overall trends, as well as to reflect that information back to the consumer and to community organizations that can connect people with better services, materials, and supplies to support and reduce harm. And in there, since our initial public health bulletin for identifying xylazine in MADS in March of 2021, we saw that xylazine continued to be detected in a substantial number of our samples that were sold as and also containing fentanyl and heroin. This is really important to have drug checking data because it could point us to the form in which xylazine was presenting. In this case, it was fentanyl and heroin, so powders presenting as that also contain xylazine, but also pressed pills, the fake M30 or Percocets, if you will, that were showing to include xylazine, and that was in particular parts of the state where we could manage and better communicate to those partners. But we did not, in our area, xylazine is uncommonly detected in stimulants. And however, we do see where contamination of powder form stimulants with fentanyl is known to occur, that xylazine and fentanyl has been detected in those stimulants. So a pattern of similar pattern to we've been seeing to fentanyl contamination, because xylazine is often contained in the fentanyl, we may anticipate that there may be similar overlap with stimulants in that regard, but otherwise not as much of a pattern. This was important for us to understand where we should be putting our efforts and communicate plainly. But just taking a moment, community drug checking, what is it that I'm talking about? Community drug checking, as we use it in Massachusetts as part of our Massachusetts drug supply data stream, which is a funded activity through CDC and SAMHSA, and in partnership with our state agency, the Bureau of Substance Addiction Services. In each of our now 16 sites, harm reduction partner sites, that could be a syringe service program, a community health center, or an overdose education and naloxone distribution program, or even a low barrier treatment program, operate the community drug checking program, and they may have different mechanisms for connecting with their clients and participants through mobile vans or outreach. And in those sites, there's collaboration and agreement with the police department or a district attorney, so that samples of remnant drug and detritus can be tested for their content and reflected back as information that people can work to reduce harm over. What that actually looks like in practice, just as a small aside here too, are the tools of harm reduction community drug checking, which include things like a Fourier transform infrared spectrometer on the left-hand side, which is an FTIR, fentanyl, benzodiazepine, and xylazine test strips, like we've been talking about. These are tools for helping to understand and detect substances and the components of the drug supply. And then we partner with offsite labs to see more specific components, and that includes both the university, hospital, and other forensic labs. And all the data are in collaboration and consultation with a medical toxicologist to make sure that we're understanding possible public health, occupational, and use concerns. And this is what xylazine followed through when we first started seeing it in 2020, going out of 2020 into 2021. And that information is compiled to be able to share back publicly on a website that we called Street Check. So streetcheck.org is where we kind of track trends both at the geographic level and the states, so local, state, and regional level. So this is information, and it's important for us to think about, but and to gather those trends. But there's a lot that we don't know about xylazine in particular. And I'll call out that I think the core component of this particular substances, we don't know what the safe dosing of xylazine is for humans. That we have extensive laboratory research on animals that show inconsistent effects of dose in small and large animals, that there potentially are genetic influences. There's a lot of opportunity to do research in this area. We suspect that there may be a dose response. So more use or more exposure to xylazine may cause more harm, but it's unclear what those symptoms are and what health effects are triggering which harms. In addition, for humans, the routes of administration, that is how people smoke or snort, or oral or anal routes of injection. Otherwise, we don't have a sense of if their routes are particularly harmful or more harmful than others. And so the safest approach is one that minimizes xylazine exposure and xylazine dose. But to understand this, we have to gather actual use experiences and effects to both prepare and better respond. So to share some of that, we've been talking about some of the xylazine related effects. I'm going to touch a little bit more upon the use experience and potentially the utility or role that xylazine is playing. But you've also been hearing about complicated overdose management, atypical skin lesions, and overdose, oversedation and treatment effects as well. And let's just start first with some use experiences. So these are data from our research study in Rhode Island, the CUT study, which is a cohort study. We just closed data collection in August. So the data that I'm sharing with you today is from February to August of this year, where we enrolled 125 people who use drugs, who are all part of our drug checking activity there. And in that case, we saw in Rhode Island, much like Massachusetts and other parts of some parts of New England and other parts of the East Coast, are emerging xylazine areas. As you've been hearing from my colleague in Philadelphia, Megan, you've been hearing that Philadelphia has had xylazine for some time at very high doses, if you will, very high rates of exposure and very high doses of xylazine. In our communities, we are seeing it emerge and perhaps have inconsistent doses. So it's maybe in that emerging environment that you'd expect that people may not be as aware of xylazine, and that is indeed the case. So just over half of the people that we spoke with in the past couple months reflected that they knew what xylazine was, and kind of half of those folks have used xylazine or drugs that they thought had xylazine in them in the past 6 months. When we asked them, how did you know that it was xylazine that you used? The responses reflected really that it was a derivation of the effect, in particular, effects that were super sedating and out of the usual amount of time that they would expect to be experiencing sedation, but also that they suffered ulcers or other lesions on their body after exposure to xylazine, or that they woke up in very bad or worse usual withdrawal. Another common response was by using drug checking programs and knowing that they were informed by someone who knew that the xylazine was in there. So social networks and the access to harm reduction programming is really important for knowing that xylazine is there and if we're going to formulate a response. The other thing that we saw, have been seeing in these data, is that while awareness of xylazine is low, there's quite a lot of indecision about the attributes of xylazine, whether these are positive or negative, kind of where they are fitting. And this is a really impressionable time. We have an opportunity to imbue the conversation of xylazine with important harm reduction messaging. The use experiences from drug checking that we've been conducting in these areas of emerging xylazine presence then are compiled on this slide. And so both from our cut study and then also from Street Check, from our community drug checking, where people can report their use experience associated with the sample that they were having tested. And we don't know for sure if they knew that xylazine was in that sample before they used it, but when we test and can see that xylazine was there, we can kind of see what they were telling us, what their use experience was. So the collection of things that we are seeing are kind of simmered down here, but many people speak to the sedating nature of xylazine, and that a number of people spoke to it as being helpful in their sleep, and that they needed sleep, and this was an aid. Others spoke of landing gear after heavy stimulant use, much like you heard from Dr. Reed. They talked about that they could use less and still get high, and this was a positive economically for them, that it boosts the high from the fentanyl that they had, that they were not feeling sick from opioid withdrawal even after 48 hours after they had used the substance. But others felt differently and said, it's a direct quote, that makes your withdrawal quicker, that it doesn't last as long, and it puts you right to sleep. But nearly the most common response was, an attribute was that it was really strong, and it was, in this person's words, some of the strongest substance that they've used in 6 months. And that was whether people were smoking, snorting, using by anal route or by injection. And other common, especially with respect to injection, other experiences were having had blackouts or headaches or feeling very dizzy or nodding off, and feeling losing consciousness afterwards. So it's very important, I think, to simmer down and understand how people are experiencing xylazine so that we can understand what role it's playing in use, and to think about especially some of these aspects of how we might be able to address other concerns about sedation, sleep, and the need for staying safe after a stimulant use. And so also, though, while it's not well understood, that we do believe that repeated use of higher doses of xylazine can cause dependence and uncomfortable withdrawal symptoms, much like you heard earlier. We heard similar things, that people who had been associating a samples experience with rash and paranoia, feeling very uncomfortable and sick, and that they were not relieved by their withdrawal. Their withdrawal symptoms were not relieved. They felt anxiety and panic attacks and dysphoria. But other experiences, especially for people who were injecting, but also other routes, unusual other experiences that people were using by other routes of administration, indicated that they had numbness at their arms, that burning and swelling at the injection site, and burning their nose, having abscesses in different parts of their nasal cavity, feeling like that the pain of the injection, and they had really quick onset of swelling. For people who were using by oral routes, losing sensation and having cold feet or a very heavy fluid in the feet were sensations. And without fail, almost everyone spoke to, especially who were injecting, concerns around wounds, and wounds appearing on the skin very quickly, as at the injection site, but also in other places. So given the additional key challenges where we don't have a commercially available assay strip to test for the presence of xylazine, and that we have naloxone that doesn't work to reverse xylazine in the same way that naloxone reverses for opioid overdoses, and that our approach to date has had a heavy and very singular focus on overdose prevention, and this approach may be insufficient to addressing some of the health impacts we've been talking about of xylazine and the drug supply. So our typical response to date has been and you heard a little bit about this earlier, from states around to look to focus on supply reduction interventions in particular. And I would caution that the data really reflect that we have, when it comes to substances like opioids that are synthetic and novel synthetic substances, especially that restrictions in one area we do end up getting sometimes more problematic analogs. And for instance, looking at restrictions on cyclopropylfentanyl and methoxyacetylfentanyl early on, resulted in a real rise, as you can see in parafluorylfentanyl, which is now the dominant analog that we have circulating in the United States, and the emergence of things like nitazene. So supply focused, especially in a vacuum, really may result in an initial reduction, but really concerns that there may be massive shifts to greater harm. A very easy replacement for xylazine may be benzodiazepines, of which we have numerous synthetic options already in circulation and pressed fake pills of benzodiazepines. And this is a concern because of the extraordinary overdose synergy with respect to fentanyl and a benzodiazepine for lethal combinations. So what were our responses? You've been hearing some of them. I would like to just sort of simmer down those as well. So a naloxone first approach, because xylazine has been present in opioids, we really see that overdose symptoms can be responded to with naloxone administration first and foremost. And there more may be needed, but to watch that breathing to determine whether sedation is the symptom that's persisting as opposed to respiratory depression. Rescue breathing and the emphasis on rescue breathing, both on supported breathing for first responders who may be using more extensive oxygen support breathing mechanisms, but also on educating community members. We have an over-the-counter naloxone product, which is phenomenal. We have greater access to community naloxone than we've ever had in many parts of the country. But rescue breathing is a key component, especially for xylazine presence, to be able to make sure that people understand how to perform rescue breathing, and also if people are to be left out of position, people in the recovery position, and that those trainings are really critical, even with an available naloxone access point. In the wound care area, while prevention and early intervention is really important, that across harm reduction providers, community health centers, and opioid treatment programs, the distribution of wound care kits, communication and awareness about wounds, including how to do a wound check, to encourage people to come in, and creating safe spaces and safe moments in the community where wound care can occur are really important. And finally, creating more accessible care, mobile health vans, and medical providers who could be on site with more regularity to provide wound care in many more places. For the structural components, preparing hospitals and clinical settings for xylazine, including emphasizing ventilatory support and the role of naloxone when xylazine is present, but also creating stigma reduction, trauma-informed care, and harm reduction trainings for our hospital and community health center partners, so that we have the capacity and the calm and presence to be able to respond with harm reduction, but also with compassion. I mentioned that earlier that we have other systems and partners on the line. So I want to really speak to the criminal justice systems as well, that people who are entering criminal justice settings with wounds are going to need wound care management. And because of the often suboptimal conditions for regular wound care, some thought needs to be put, I think, into the placement and planning for our criminal justice system, so that addressing both and raising the awareness or that stigma around wound and wound care presentation, as well as how to better provide care, is important. But people who may be leaving post-release may not be aware of xylazine and how to identify wounds and how to stay safe post-release. So information and education at the level at post-release is an opportunity to improve. And then finally, we see that starting and continuing medications for opioid use disorder will reduce the risk of opioid use, period, and opioids with fentanyl and with xylazine on board. This is a pathway to ensure that MOUD starts and continues in a correctional setting. Programs that in states that are doing community drug checking should continue to do so, and to expand them in generating data like like we've been seeing in Massachusetts, the ability to create plain language and really targeted and helpful for on the left-hand side, we created some public facing and community messaging, and on the right for first responders, police and EMS to clarify and raise awareness about Xylazine, and to use the kind of techniques and messaging that would be appropriate for those communication groups, and to provide that in responsive and inclusive languages and messaging. And lastly, just to remind, I guess this is an opportunity to share that there are a number of cutting edge research projects underway. The Xylazine test strip validation amongst community drug checking programs, seeking to understand some of those sensitivity and specificity and performance of test strips in community drug checking programs, should be wrapping up and have data to share in the next couple weeks. You've heard a little bit about responding to Xylazine in terms of public safety, and other community-driven responses to Xylazine that hopefully will, each of them will provide more directed research and suggestions and guidance. And then finally, some really wonderful clinical supports for health and medical professionals on care of people with exposed to Xylazine and experiencing Xylazine-related problems are all underway. So lastly, I'd like to take home points. The drug supply is in a state of enormous flux. The unregulated and toxic nature of it is part of that change, and Xylazine is very much part of that change. So adapting to Xylazine for all of our approaches is important because it is now, and it has already been in the drug supply for some time, and we should expect that use will be there. We should look to see that there are things that we can do in the community to stay safe, and that we can do to respond to help reduce harmful effects even sooner. But a lot is changing on this topic, so I hope to see an opportunities for forums like this to revisit the topic and see what we've learned since. A last message of hope. I do hope that we learn from Xylazine that some supply-only restrictions and scheduling isn't a response that will necessarily help here, that we can see the value of community drug checking and consumer safety and elevate the health of people who use drugs, and find efficient and multiple pathways to treatment for opioid use disorder, and that self-management guidance for wound care can help people who are experiencing wounds and in the community to empower them to respond as they have with tools for overdose and starting buprenorphine and responding to overdose similarly. And then we should be thinking about metrics that help us see how our impact with Xylazine have been effective, not just in mortality reduction, but actually in the quality of life of people who use drugs. Thank you very much. I look forward to discussing.